Welcome to the ICD-10 workshop.
I wanted to introduce myself to those of you who are brand new to joining us today. I am Kelly Whittle. I'm the owner of Whittle Advisors, and I do ICD-10 transition planning, not only for hospital systems, but for clinics and physician practices. Welcome to workshop number 4. We have lots to talk about today, and some pretty exciting things happening in the industry. So we're going to go ahead and get started. We're going to take some time this morning and talk about, from a community's perspective, what the congressional action means to us and how you're responding to that. And then we'll share some ongoing support for you and some contact information. Since some of you started spring break, Congress has been very busy. On March 27th, the House of Representatives passed a bill to stop the impact of the sustainable growth rate. Is everybody familiar with the sustainable growth rate, the SGR? The SGR is a mathematical formula used by Congress to, it was initially decided that it would balance the budget of Medicare, but then the cut to Medicare payments were so drastic that they couldn't actually go forward with it. So they've been kicking it down the road in time, the proverbial kick the can, for many, many years. Well, this year we had tallied up about a 24% cut to Medicare payments. Certainly that's not sustainable. So at the last moment, they kicked it down the road. And part of that kick was to slide in a delay to the ICD-10 code set. If you do any of this type of congressional watching, you'll know that it's really interesting that the House of Representatives added these 7 lines to postpone ICD-10 in the middle of paragraphs all about the sustainable growth rate, which the two aren't even connected. And it wasn't indexed, which is really interesting. Nowhere in the index did it say delay to ICD-10. It was kind of buried in there. And so, surprise, we ended up with the House of Representatives passing the sustainable growth rate, which everybody agrees to, but as a side impact, a delay. Then it moved to the Senate, and the Senate did a vote on April 1st, and they also passed the exact same bill. Then last week, President Obama signed it into law, and so now we have a reprieve from the impact of the sustainable growth rate, but what we have is a delay of ICD-10 until at least October 1, 2015. That's terrific. So the slides that we're going to review now, the information I'm going to share, you're going to find really valuable. We're going to talk first about some key transition considerations. And if you recall from workshop 3, we had spent some time during workshop 3 talking about some broad strategies like dual coding, testing, making sure that your vendor systems and vendor partners are prepared. And the partners are along the business line. So if you have somebody doing your billing, you have somebody doing backup coding, whatever your vendor partners are doing for you, it's important to stay connected with them and to move together in a coordinated timeline. So this morning we're going to pick up from that point, from workshop 3. And we're going to talk about the key considerations before you go into a go-live environment. And I'll explain go-live in a few minutes. The first one is coding productivity. Now, some of you might think coding productivity, I don't even have coders. My providers pick the codes. That's okay. I want you to think about your provider's productivity. If your providers are the ones using the EMR, choosing the codes, there will be an impact to that process. So I want you to consider your provider's work here as well. When you start to see your upgrades in the EMR, you'll begin to see that while many of the EMRs are giving you tools like IMO to help you drill into the specificity of ICD-10, there are many, many more codes. And where our pilots are showing us that providers get stuck is in the deciding the differences between the variations of the codes. They're very minor differences or very specific differences between many of the codes. For example, in ICD-9 today, there are about 4 codes for laceration of the finger. In ICD-10, there are 1,800. So you get very detailed very quickly. That is going to take a lot more time for them as they try to identify the code that is most specific and most appropriate. So when you start your training and your providers start to work in the new language, have conversations with them regarding how much more time is it taking you. Our pilots, if you recall from Workshop 3, we're finding about a 200% increase in time to identify a code over what they're doing today. So if you have doctors that are very specific in their documentation today, they might tell you it takes me 5 minutes or 7 minutes per patient to do my documentation. If that's the case, you can expect somewhere north of 11 or 12 minutes and more for them to process a patient record. That's likely to cause a lot of concern on the part of your providers. They're going to ask for things like cheat sheets, additional education, maybe this concept called a scribe, where they're not the one actually dealing in the system, all of which are viable solutions based on the needs of your practice. So outside of coding productivity, you'll want to think about coding accuracy. If your providers have the role of choosing your codes and you don't have coding staff in your practice, the coding accuracy piece is a lot more difficult to determine. Some practices will determine the coding accuracy by bringing in an outside company to take a look through chart reviews to determine the accuracy. A very ineffective way to determine your accuracy is to wait for rejections or rework to come back from the payer. Some of you will decide that that's a really good strategy, and it's okay. Certainly the payers will tell you if it's accurate or not. But CMS tells us in the actual ICD-10 law, the HIPAA law, that from CMS's perspective, you can expect a 10% increase in rework due to Medicare claims. Advisory board says if you look across all payer types, you're looking at somewhere close to 25% rework due to the I-10 transition. So if you're seeing 100 claims per month today, 25% more is what you can expect when we actually get to the transition. Any questions about coding productivity and coder accuracy? Let's talk about anybody here actually have a job role coder that does a review of the encounters before they get billed. So if you have true coding functionality in your practices, you have a level of protection, if you will, against the rework and the change to the documentation. Are your coders receiving the right level of education to master the new I-10 language? Yes, great. You're setting yourselves up to be in a really efficient process. Based on coding productivity today, you can expect somewhere around a 25% coder productivity loss. The coder productivity loss is very different than the provider productivity loss. The providers are still going to give all the documentation to your coders. And so because the pieces are broken into two different roles, you should see less of an impact versus the doctor having to identify the codes while they're working with a patient. That becomes more cumbersome.
Hey, Kelly, how would the insurance companies, if you're picking a real specific code, how would they know to ask for, are they going to be asking for documentation on certain codes? Or why would they reject if you pick a real specific code? Why would there be a 25%, look at that or denial?
So many in the industry believe it will be based on those payer edits. All payers have these very complicated algorithms on what they pay and what they don't. And so when they receive your CPT codes and your diagnosis codes, that is going to go into a system, and the system's going to parse whether that's a payable diagnosis or not. And so all of those edits have to be changed. And there's thousands and thousands and hundreds of thousands of them. And if they haven't done that exactly right, it could be a payer side error that gets rejected, or it could be a change in the policy of what's covered. Both of those areas are potential risk for you.
And is it a secret as to which codes are covered and not? Or is there a way for us as providers to go, well, they don't cover this code, but they would cover this code? Is it just a trial and error? Is that the game?
Actually, your questions are perfect. Thank you. It isn't a secret. It is harder to get straight answers from private payers, commercial payers. So the Blue Crosses of the world, the Aetnas of the world, some of them are better than others at posting what they call medical necessity edits, and you can pull some of that from their website. The problem is Blue Cross Blue Shield of Michigan is notorious for updating those rules, business rules, and not getting that latest information to their website. So you can take what they have, and certainly that's better than nothing. CMS is great at this. They put out NCDs and LCDs, and based on those determinations, you can find out right away. There are other tools in the industry that will allow you to do these medical necessity checks prior to doing your billing. And so if you're using a NextGen system, NextGen has an add-on that you can purchase. Back in the day, it was $250 a year added on to your service contract to give you this medical necessity module. I don't know what the price is today. That was about 18 months or 20 months ago. I had heard that price, $250 per provider. I want to make sure I say that, per provider. So if you have 4 providers in the office, $1,000 a year to have this add-on. But if it saves you on rework, it's absolutely worth the fee. There are other tools like that in the industry that you can add on to your systems.
For eClinical, is there anything?
You might want to ask your eClinical vendor if there's an add-on. And then through trial and error, if you keep getting a rejection for a specific combination, you can start to build in the edits. If you have the software that allows you to program your own edits, you could build it into the system, and then every time you try to pass that combination, it won't drop the bill. It'll tell you there's a problem. Okay, the next consideration is contingency planning. Contingency planning is this big ball of a concept that consultants love to talk about. Sometimes they make a lot of money in contingency planning. All it means is think about your biggest risks. It's different for every single practice. So think about your biggest risks, identify 2 or 3 of them, create a worst case scenario, and then think about what would I do. Sometimes it's as simple as if our systems go down, and that happens sometimes, how are we going to keep our operations moving forward? Most offices will result to something like a paper-based process until their systems come back up. That's certainly contingency planning. If you think about the transition from I-9 to I-10, the entire industry going to it, payers having to get those edits right, and managing this bulk of work that's coming in, being parsed differently in their data systems, what if their data systems slow down and I don't get paid in 30, 60, or 90 days? Contingency planning would say, I need to have this amount of money to keep my operations running until the system starts to pay on claims again. That's another type of contingency planning. If you think about your practices, what might be the biggest risks associated with a transition? What would you want to plan for? Cash flow. Definitely cash flow. Yep. And so if you had a big stack of cash in the closet, great. If you need a line of credit, certainly talking to your creditor prior to go live is a good plan.
Anybody approach Blue Cross and Blue Shield to, like we get a certain amount from Blue Cross and Blue Shield pretty much every week. That's pretty standard. Has anybody proposed, physician groups or whatever, to make a proposal to the insurance companies to keep revenues up and afloat, that they do payments of some sort of general payment from your previous payments? Anybody approach that?
Absolutely. That has been a key strategy going on the national circuit for some time. When I was at Trinity, who's a national organization, they tried to leverage some of those concepts and negotiate with payers like Blue Cross, as well as CMS. CMS makes these pretty standard payments to hospital systems over and over again. Trinity didn't get anywhere with that conversation. The payers came back with the concept that in 6 months or 9 months, we're going to end up with this incredible amount of work to right size the payments that were paid out. So they were trying to avoid settling with all of their individual facilities. But certainly worth having a conversation. Okay, that's contingency planning. The impact on potential reimbursement. Certainly, finishing your analysis of the impact to your reimbursement is important, and shoring up those funds will be helpful. Think along the lines not only of are we getting the money that we've earned back, but if our billing process slows down, where could I get an extra FTE or half FTE to help in the billing process? And sometimes that's training somebody in advance for an on-call type role, or sometimes it's partnering with a billing service just in case you need the additional support. Let's talk about go live tasks. Now that we're looking out to October 1, 2015, which seems a gazillion months away, think about what was I preparing to do this year that I might do next year? For example, in our go live planning, we have to prepare for the impact at the point of transition. Some organizations would look at staging or preparing a go live task force a certain number of days prior to the go live date, and then a certain number of days post go live. ICD-10 is one of those transitions that will have an impact on day one, but unlike a technology transition, the pain isn't totally felt on day one. Much of the impact of ICD-10 won't be known until sometimes 30 or 45 days after go live. That's because it's all based on documentation. Do you have enough documentation starting on day one to get your bills, your claims paid in 30 or 45 days? So on day one, it might seem smooth sailing, but this is the time when you need to think about doing those random spot checks of the documentation to make sure that you're completing the records have enough detail, the providers aren't reverting back to unspecified codes. Because remember, there are unspecified codes in the ICD-10 code set. They have not been eliminated, they are there. So you'll need to do some spot checking along the way to make sure that you're getting enough detail. The key to go live and keeping go live successful is a great communication plan. Helping those with specific roles in your organization understand their individual impact will be important. So 1 or 2 weeks prior, we have to assume by 2 weeks prior to go live, everybody has completed their education, they're aware of the transition, and they understand your individual practices plan for managing go live. At that point, you'll want to make sure that they understand who are the point people if questions come up, and how to log and manage concerns. Sometimes they're called issues, sometimes they're called problems, sometimes they're called concerns. Whatever you call them, have a consolidated way to aggregate all of those problems into one place so that your go live lead can make sure that those issues are being addressed. For example, if you're using a paper-based encounter form and the encounter form gets rolled out at go live, you start to use it, and a provider or two isn't finding it to be as effective as it should be. Maybe it needs to have an additional concept added to it. Maybe the concepts are too vague. You might need to do some adjustment. When those types of feedback come back to you as program leads, write them down on your issue log and then address them as a group. Encounter forms is just one potential risk. Other risks could be unable to find a new I-10 compliant order set. You're not sure where Munson sent it. They sent you a folder, you've lost the folder. Whatever the issues might be, you'd want to aggregate them in one place and manage them over time. Now outline your steps for how your issue log should be created and to whom to contact. So if you have a technology lead in your office, you have a billing lead in your office, you'll want to make sure that those folks are aware of the impact of the change and how to handle concerns. Now, all of you said you're going to continue, and so here are my recommendations on what to focus on now and what to push into the future. To complete now, certainly you should be past your vendor assessment and inventory. should be well aware and have a documented list of all of your vendors. Your budget for fiscal year 15. You're going to still need that budget. It doesn't go away now that we have a delay. In fact, instead of a fiscal 14 and 15, you would have needed a 14, 15, and 16. So it increases, the delay increases the need for additional monies set aside to handle the transition to I-10. Remember, your fiscal year 15 budget was to cover things like technology upgrades, training from your vendors, educational programs for your impacted roles. You would want to include in your budget any productivity loss or costs associated with productivity loss. If you're doing any backfill or alternate staffing to cover the productivity loss. The thing that you're going to move from 15 to 16 are any costs associated with education. So if you've accessed Precise, for example, and you're using Precise to educate all of your various impacted roles, you might consider extending access to that education into fiscal year 16 for refresher courses. If that's not a possibility for you while you have access to Precise, find the printable or downloadable versions of those courses and save a copy. Then you can look at those again in the future. Your go live expenses you'll want to push off into fiscal 16. Your technology inventory and strategy should be set by now. You should be well aware of which pieces of technology require upgrading and which pieces you can wait on. System upgrades should be implemented on track. So whatever your milestones were for this year, keep moving. Don't slow down in that part. You don't want a delay in the system upgrades to cause you issues in other areas, whether that's billing improvements, meaningful use, or other functionality that you need. Coder biller training, you want to continue this. As soon as your coders and billers are trained, think about implementing that dual coding program. Not 100%, but two encounters a day or 3 encounters a day. And then look at your calendar now that it's been extended and think about when's the right time to ramp up dual coding. If we're doing a little bit now, how much could we do in the summer? Could we add 3 or 4 encounters a day? Could we target encounters that are high dollar type encounters and practice only those encounters when they come into our office? Provider I-10 awareness. Encourage your providers to continue on the Munson education program. Munson's providing them awareness training, specialty training, regional meeting training, etc., etc. Get them to utilize all the resources that are available to them from an awareness perspective. Consider doing clinical documentation review. Now that we have additional time, do those audits. Pop in there and say, are we missing something? Can I add some detail? If we had documented a little more of the past history, could I increase the E&M level of my visit? We talked about that at our last workshop. Process remediation. If your billing process is cumbersome and slow today and you have found opportunities to make efficiencies, move forward with that. Any efficiency that you are preparing to do for I-10 will benefit you in I-9. There's no reason to stop those improvements. Dual coding we've already touched on, and then the paper-based forms. I encourage you to move forward with paper-based remediation as long as those paper-based remediations don't include ICD-10 codes. Remember, you cannot bill with I-10 today. You're not going to bill with I-10 in 2014. It will not happen until 2015. So any tools that you've created that are specific to ICD-10, hold them. That's the pieces you want to push forward. Now for the other items to push forward, your clinical staff education. These are your RNs, your MAs, those that aren't doing billing or coding and are not providers. We want your providers to keep learning. We recommend that your clinical staff get their education pushed forward to April of 2015. So that's approximately 1 year. If they've already started, fine. Just make sure that whatever educational program or strategy you're using, you can leverage it again in April of 2015 for refresher, or that they capture their learning by taking adequate notes, taking a copy of the educational program that you have access to. The I-10 versions of your paper-based encounter forms. Is anybody here creating an encounter form that will include I-10 codes? Yes, okay. So you'll want that version of your encounter form. You could develop it now, but you definitely want to save the use of that and testing of that until next spring. There are some specialties that have a great opportunity to take their I-9 encounter form and just transition it to I-10 because there's only a handful of codes that they use. Most of us do not fall into that category. Your fiscal year 16 budget, the target timeline is on your regular budgeting cycle. So if you have an end of the year budget cycle, certainly include I-10 in your fiscal year 16 budget process. And then internal and external testing, I've given this a little asterisk. If you have plans to do internal and external testing today, I want you to continue with that plan, barring testing for I-10 outcomes. So what I mean is, when you get your system upgrades, if you had planned to do some regression testing or some unit testing to determine the quality of the content of ICD-10, I don't want you to do that this year, because you're not going to use that content for billing until next year. I want you to push that piece of testing into next spring. If you're going to do internal and external testing with payers, I want you to prepare for that, and I want you to do that testing. If our payers have engaged you to do any type of testing, continue with that. You will find it very beneficial this year, and it will help you to define how much work you have next year. So I don't want you to lose that opportunity. What I have brought you for this section is called a program harvest, and this will be a document that will get into your hands. What it is just a report template that allows you to take a pulse on where your preparation has taken you to date. So it'll allow you to gather all of your team structure information, all of your progress across various components of our program. And then by taking some time over the next week and documenting your progress, really thinking about what is going well, what is not taking hold, what's not tracking well, where might we be falling behind, where are we leaving gaps behind us, what are the things that we find most helpful. You'll have this reference tool to fine-tune your strategies, but it's also a way to help you to remember where you are if you decide that you need to slow your progress or come back to it. Remember, we're not recommending that you set the program aside. We're recommending that you really focus on clinical documentation improvement. But in the event that somebody's provider will say, we're going to not talk about this for 30 days or 60 days, you'll have this tool to come back to help you remember. It will cover all of the progress that you've made from your technology and vendor assessments, how well you were doing in your fiscal year 15 budget, your system upgrades, your biller, provider, coder, clinical staff education. It'll ask you what tools, educational tools, you're finding beneficial. If they have a title, for example, if your coders have 25 different courses to take in the program that you've selected, which of those courses were most beneficial for your organization? If you can identify it by chapter or by title of module, you'll find that to be very helpful in case you need a refresher next year. Process remediation. Give exactly the status of your process remediation. Reference any documents or files you might have tucked away in your filing system. All of this detail that you're pulling together will be a map of sorts to help you if you need to come back to it. Okay, thank you very much for your participation today.